It is Dr. Vishali.
Thank you, sir. So I'll be talking about some interaction in uveitis. Now, before we start doing interaction, what is uveitis all about? Just imagine a jumbled up pile of books lying there, because there are 387 conditions which produce uveitis and one can resemble other. So you want to find out what condition it is. It's like finding the right book. Now, if you have to go over this pile, maybe by the end of it, you will be able to find a book, but maybe you don't need the book by that time. So how would you organize yourself? The way you organize yourself is the books are cataloged. So when you have to reach the book, you just browse over a little rack which has about 10 or 12 books, so that you can take out the book very promptly. So that is how the uveitis is. So how should you practice uveitis? Just do a very basic general history. No need to go into the sexual behaviors and homosexuality in all the patients of uveitis, because they are not going to give you the history anyways in the beginning. So just ask very basic simple history. Do a comprehensive ocular examination to get an idea what you are dealing with. Go back with the specific questions and then examination. So how do we work it? And I'm going to interact with you all in the next cases to show you how quickly can you reach the diagnosis. The first and the foremost important step in uveitis is to be able to name the disease, and we are going to discuss how to name it. Once you name it, you mesh it. What are the known entities that fit into this name? And that makes it very simpler, because then you investigate only those entities and not the entire gamut of investigations. So imagine and go through with me. Just imagine you are sitting in a clinic, a patient walks in, and he complains of decreased vision in the right eye since 4 weeks. It is insidious onset. This is very important. You got to ask what is the onset. Patient has been using some topical steroids 4 times a day. He also has a red lesion involving the tip of the nose, and there is no other systemic disease. Now, what do you see? Any of you just shout. So what do you see on the cornea? Absolutely fine. So you see granulomatous form of keratic precipitates. Anytime you see the formed keratic precipitate, it is granulomatous uveitis, okay? So you also look at the pressure. Pressure is 8 millimeter. It is very important to look at the fundus, because it could be a part of pan-uveitis and not only anterior uveitis. There is just 1+ vitreous cells, which means it is predominantly anterior uveitis. So what do you have now? This is what I said, you have to name the disease. So how would you name it? 40-year-old man, unilateral, insidious, granulomatous anterior uveitis with nasal redness, okay? Now try to mesh the diseases that you know of into this name. And if you think about it, there are not many diseases you can fit into. You won't think of SLEs or JIAs or other things, because it is granulomatous form. So what would you think of? It could be TB or it could be sarcoid. And very important these days, the patients that we have on rise are the viral anterior uveitis. So it could be either of the 3. So within 5 minutes of examining the patient, you have just 3 differential diagnoses which you want to rule out. So which one of the 3? So now you go back, talk to the patient with a very specific aim that you are talking about either of the three entities. Patient's corneal sensations are normal. IOP is 8. If it was viral, the IOP is elevated. So any patient of granulomatous uveitis with increased IOP, always think of viral, because no other form of uveitis causes the raise in the IOP. Look for corneal sensations, which would be reduced, and look for transillumination. In this patient, they are absent. But he has a nasal rash. What could nasal rash be due to? What nasal rash makes you think of uveitis patient? Herpes, Hutchinson sign, no? So you look at what the lesion is. He has a plaque-like lesion near the tip of the nose. So it doesn't look like viral. Two things which you always remember if you ever want to practice uveitis. Always let your ego go. Learn to say, I don't know, ask for help, and never ever make a diagnosis which you cannot revise next day, next week, next month, or maybe 20 years later, because uveitis will keep evolving. So like in our institution, the residents have a habit. They look at the file and they say, a known case of VKH. There is nothing like known case in uveitis. What we say today may be wrong tomorrow. So I do not understand what this is, so I need a rheumatologist to help me out. In the meantime, the viral is already out, so we are between TB and sarcoid, okay? So how would you differentiate? You just ask any history of TB in the family, any history of treatment in the past. He says he does feel weakness, fatigue, and breathless on exertion, but there is no history of exposure to tuberculosis, okay? So which investigations would you order? Anybody would like to volunteer? It's interactive session, come on. What investigations would you give? Montius, okay? Another principle in uveitis are probably every medical specialty is don't just order the test because you have read about it. Never ever order the test when you do not know what you are going to do when the result comes, either positive or negative, okay? So what will we do here? We will order a very simple basic PPD skin test or the Montius test, and you have a plan. You have a plan that if Montius test comes positive, I could think of tuberculosis. If it comes totally negative in the population like ours, which is exposed to BCG, it could be very strongly suggestive of sarcoidosis. Okay, so either ways it is important. So I'm ordering the Montius. You could order chest imaging and be very careful, because on chest imaging, you are not looking for cavitary lesions. No, that is, you are not going to go to the pulmonologist or to radiologist and say, X-ray is normal or there is no evidence of TB. You are looking for exposure to TB, which is a Gons focus, some calcified nodes somewhere, But if there is a significant hilar lymphadenopathy, I'm thinking of sarcoidosis. Quantiferon TB Gold, I will not even order now. So in the meantime, it is also very important. You start the patient on topical steroids, cycloplegics, you know you need to consult for nasal lesion, and you call the patient after 72 hours with a very simple plan. If PPD is positive, if it is suggestive of TB, I will add ATT. If it is not suggestive, I will see what I can do for sarcoidosis, okay? So let's see how it evolves. Patient comes back to you after 72 hours. Montius is negative, and you see these hilar nodes. What do you think it is? Shout. TB or sarcoid? Sarcoidosis, wonderful. So that is how, you have not really done much. You have just seen the patient, ordered two very, very inexpensive investigations, and you have already reached a diagnosis of systemic sarcoidosis. Isn't that wonderful? But you still don't know what the thing was on the nose. So my rheumatologist says it is something called lupus pernio involving the tip of the nose, which is very classic about sarcoidosis. Okay, so we are almost nearly there, but whenever we talk of sarcoidosis, we like to have the biopsy. But if we look from patient's point of view, within 72 hours, his vision is improved because you are giving treatment, anterior chamber inflammation is reduced, and you are nearly there with the diagnosis of systemic sarcoidosis. What next? As I said, if you think of sarcoidosis, you need biopsy to confirm. But you have two sites now. You have the lymph nodes beautifully seen on X-ray, and you have a skin. Which one would you prefer? Skin, because the basic principle is first do no harm. So whenever you are thinking of the patient, you choose the one which is least invasive, and in this case, it is skin. So here you go. This is the skin biopsy that confirms the sarcoid granulomas, which are non-necrotizing compared to necrotizing granulomas of tuberculosis. So you just made the diagnosis of systemic sarcoidosis and prevented this patient from going into the interstitial disease because you were smart enough to pick it up. So it doesn't require very hi-fi investigations. It just requires the art of application of medicine, which unfortunately we forget in the branch of ophthalmology. So what happens 2 weeks later? Not only have you taken care of his eye, you have also taken care of his nose and of course of his lungs. So the take-home message is don't clutter your mind, just go systematic, because systematic approach is going to save time, efforts, as well as the money. Because you sitting in the tertiary care referral institute, you see patients carrying huge file, from patient to, from doctor to doctor and investigation to investigation, but none of those investigations are decisive. So don't do this to your patients and to yourself. The second mistake which we all make is we are somehow used to of looking at the eye. Sometimes we even forget that it is a complete patient who's walked up to us, and it's not only the eye. So I will give you an example. This again is an 8-year-old girl who comes with the inflammation, and you see the capes. These capes look like exactly the same I showed you in the previous case, where I said it was granulomatous anterior uveitis. But I also said always look at the fundus before you name the disease. Now this is the fundus. It shows a huge amount of exudation, vasculitis, exudative retinal detachment, and this patient was diagnosed, she is actually from this city only, so she had been to a lot of places and was diagnosed Coats disease, vasculitis, retinoblastoma, you name it, and the label was there for this patient. So what do we do? First is, if it is Coats disease, it should show some aneurysmal dilation. And how can I pick up those aneurysmal dilation? By simply doing a fluorescein angiogram. So you do a fluorescein angiogram. This is just to show you the left eye was normal. Now look at the fluorescein. This shows the presence of capillary leak throughout, and there is some disc hyperemia, and inferiorly it was dark because there is exudative detachment. But I'm not seeing those lighted bulb or those aneurysmal dilation that I would see in Coats disease. So if there is not so much dilation, how do I have a mound of exudates there? In the late phase, there is a diffuse leak. It means she does have vasculitis, but she doesn't have Coats disease. So what possibly it could be? Left eye is absolutely normal. So next step, Unilateral retinal vasculitis, young girl. This is the name for my disease, quartz-like response, what it could be. That is what I told you, that first you do the examination and then do the general physical examination. You do the general physical examination, the child is very different looking, and we have the permissions of her parents to show the pictures. So the external examination, when you look, there is a right-sided hemifacial atrophy. And there is also zygomatic bony prominence that I will show you, and there is atrophic periocular pack. Now you see, this is what I mean by zygomatic prominence. And the father quickly takes out the previous picture and says, both the things have been going together, like the problem in the eye and the progressive atrophy. He says, my daughter was normal. It's just last 1-2 years that her face is looking like this. I honestly did not know what we were dealing with till we got into it, and it is something called Parry-Romberg syndrome. I think my chairs here would know about it more than me. But anyways, this is something that shows reduced subcutaneous mass around the right eyeball, and this is confirmed on CT. That's not the point. This is capillaroscopy, and this is of course published now. But the moral of the story is the management changes. Instead of just managing your uveitis, our codes, are doing lasers, are doing whatever you would like to do, here your aim also becomes whether you are going to prevent the progression of the disease. So the patient is shifted onto biologics and of course planned for surgical management with the bone and fat graft. So the take-home message is, please look at the patient as a whole and not only at the eye. And I think I have time to discuss just one more this, which is actually opposite of what I have shown, that sometimes phenotype in the eye may not be related to disease that the patient has. This is a 23-year-old male who comes to us with sudden and progressive decreased vision in both eyes. It's a very interesting patient. Patient was a known case of IgG4 related disease, and the differential diagnosis was something fancy, SAPHO. I will not go into details, but both of them are autoimmune diseases. So patient comes, he's carrying this OCT scan, which was done a few days before, and he says, I have sudden decreased vision in the right eye. OCT looks kind of not something which at least I have ever seen typical of anything. This is what the fundus looks like. There are some whitish lesions at the level of the outer retina, and there is some funny linear lesion here. And this is the left eye. And he's just a young boy who's counting fingers in both the eyes. He has IgG4. So my first thing was, oh, it is IgG4 related disease because patient is a known patient of IgG4. So I kind of promptly admitted the patient, talked to pediatrician, planned for IV methylpred, because that is what we do in uveitis, and that's what everybody thinks, that uveitis people are synonymous with steroids, which unfortunately is not true. Now look at the autofluorescence. Look at these, linear. Look in the left eye, something very different. This is not what choroiditis looks like. And this was the giveaway sign. This is kind of a pillar in the outer retina, and this is growing like this. So even though patient had IgG4, this does not fit into the systemic phenotype. So it's not only you look at the patient, you also look at the eye. So don't start pushing steroids because patient has an autoimmune disease. Look at this. So to cut the story short, the fluorescent was not typical of anything, neither was the ICG, and what we had missed was this typical OCT. This OCT is very highly suggestive of laser-induced maculopathy. So don't miss it, because there are a lot of children now with the toys, with the pointers, with the laser pointers going around, And when we asked this patient, he says, yes, he had been to Goa, bought a Chinese laser, and was, they were playing and throwing it into each other's eyes. So, and this is the literature which shows a similar case. You can see this. This is what, if you don't understand it, ask for help. And in my patient, a dear friend, Bailey Front, helped me in reaching the diagnosis. So look at these linear scars. So Bailey had reported it earlier. This is laser-induced maculopathy. So of course, this is what patient told me, what he had bought. So you may see more of these patients. So we have published now in retina, but that's not the point. The point is, when you are practicing uveitis, please be very careful with what you are dealing with for two things. To reach the systemic diagnosis. Number two, to prevent the morbidity as well as mortality. I don't have the time, otherwise I would have taken you through lymphomas and all that more dangerous stuff, how you can diagnose it. And sometimes, like in this laser-induced maculopathy cases, you can actually prevent the starting of immunosuppression, because many a times you realize patient with Fuchs disease, and Fuchs is known to have some vitritis, they are on steroids, they are on short of biologics, they are on everything, because we don't understand the phenotype. So that's all I have to say, and you're welcome to ask any questions.
Thank you, Dr. Vishali. So now the house is open for questions, since we don't have the next speaker yet coming for that time. If there are any questions from Dr. Vishali or Dr. Feroz or from me, you're welcome. So if anything that is not clear or you would like any other clarification, please raise your hands and question.
You won't get this chance. Again, you have like the doins, like Dr. Vishali Gupta, Dr. Pradeep Sharma here. No questions? Either you understood everything or things have flown beyond.
Or it was like post-lunch siesta. Slept through. It's like that joke, that person said that how was my talk? A speaker asked, and the person got up, he said that the first half was a little problematic. Why? There was some disturbance, I could not get through, and the second half you could understand, then I slept through. So hope you had a good sleep through that. Any questions, please? So we have an enlightened audience. We really feel good.
Any interaction? We're just waiting for Dr. Santosh Onava. The session is till 5 p.m. So you actually have time, 5 more minutes to discuss. We have some bright students sitting in the last bench. No questions?
Or comments?
Yes, you.
Maybe if
Not
you have.
Srinivas. Next to you. Any comments?
Okay, sure, Srinivas.
So meshing is very important, okay? Because what you label on your paper during a diagnosis in uveitis is extremely important. You label it as, is it acute, is it chronic, is it anterior, is it posterior, is it pan-uveitis, so that you come to a provisional diagnosis. And like ma'am said, it's targeted approach which is very important. Otherwise you will be ordering all sorts of tests, and when the results come in, you are totally confused as what to do and what not to do. So it was a very, very important and extremely good talk. I've not heard her talk before, but I've heard about uveitis talks a lot, but this was very well done. Thank you, ma'am.
Ma'am, I have something to ask you. What would you like to advise the students? Like, if a case of uveitis comes, how would an examiner want them to approach it?
Don't jump into all the investigations at once. First, do a rehearsal in your mind. that what you are seeing. For example, if you are seeing a young girl, 6-year-old, band-shaped keratopathy, complicated cataract, so what it could be, the first thing that should come to your mind is loud. I'm getting old. JIA, isn't that? Nothing else comes to your mind. So when you have seen it, you have put down like those telegraphic language, that is naming. So you say 6-year-old, bilateral, chronic anterior uveitis, BSK, complicated cataract, and maybe if you are seen at the advanced stage, there is hypotony. Now it's a non-granulomatous uveitis, so there are not many things which will fit into it. The first thing you will put it is a JIA, and the only investigation you would need is ANA. So no need to get Monteus and everything for every patient. Just do whatever is required for that patient. So that was just an example. So if you are able to name it well, mesh it well, you would automatically get very few investigations, and it would be very useful to reach the diagnosis. And secondly, you have to be aggressive in uveitis management. Don't be scared, like you see the first patient, granulomatous anterior uveitis with those KPs, and somebody is given 4 times whatever steroid drops. That's a joke, So you have to have zero tolerance for inflammation in the eye. And if you decide it is inflammation and it requires treatment, then it requires treatment. Then there is nothing like steroids will raise the pressure or cause the cataract. There is nothing like it. Then be aggressive about it. So that is the second message I would like to give. And third is, if you don't understand, then of course seek for help. If something you don't understand, you want rheumatologists, you want radiologists, but don't go away with the impression that uveitis is all about molecular biologies and PET scans and all those. We do talk of that in the meeting, but that is only for very select, challenging patients. So the normal uveitis, majority of it should be handled by the comprehensive ophthalmologist, because it does not require too much of knowledge. I mean, it requires knowledge, not too much of lab backup. Yeah.
On ocular oncology perspective, there is some principle that we believe. Extremes of age, be it a child or an old man, there are few things that we keep in mind. In a child,
We do also.
Yes, retinoblastoma and leukemia, or even ciliary body medulloepithelioma in a child. And if it's an extreme old age patient, lymphoma is something that we always keep in mind. So this is like we always follow this principle in ocular oncology.
We do in uveitis also. The autoimmunity occurs in the middle age. In children, there are not too many autoimmune diseases except JIAs and now BLAUs and all that. Autoimmune system, I think, gets tired after the age of 50. So any patient coming to you for the first time in the later part of the life without any history of previous episodes of uveitis, always think about Masquerade syndromes. The second is look at the type of the cells. If you think those cells are bigger than the WBCs, there are no synecdoche formation, or there are something which is not usual. Like my next patient was actually lymphoma, which was a very interesting patient, but I think I ran out of time. But if you feel anything unusual, then you start thinking of masquerades. So when do you think of masquerades? One is extremes of age. Second is patient is not responding the way you want the patient to respond. So you have seen uveitis or vitritis, you have started on therapy and patient is not responding, or there are too many recurrences, or there is something which just doesn't feel right. So those are the kind of the patients you have to rule out masquerades. And lymphoma is somehow on rise. Like I see one patient every week of primary vitreoretinal lymphoma. I don't know whether I'm attracting them or I'm diagnosing them, but it's really even in the younger age group, like 30s, 40s. So that thing of 60s, somehow it's changing for us. we are seeing lot more lymphomas in the younger
Younger
age
age
group.
group.
Yeah.
Thank you very much. So I have this question for Dr. Pradeep